Why don't we talk like 5 minutes about follow-up issues in patients with atrial fibrillation, anticoagulation after catheter ablation, which is very, very relevant, and address the question whether or not we should treat patients that approach us with mildly symptomatic, even asymptomatic atrial fibrillation, and want to get rid of anticoagulation. It's a discussion that all of us have gone through with the patients. CHA2DS2-VASc score of 2, mildly symptomatic atrial fibrillation, and the patient wants to get rid of anticoagulation, approaches the EP specialist and say, give me an ablation, and then take off the warfarin. Fine.
Very difficult question, otherwise you wouldn't have asked it. I would give a very balanced answer, and I say, well, we don't have very hard data to support the indication to stop anticoagulation as being a reason for an AF ablation. If the patient would push me nevertheless on the issue, I would say probably yes, if I may implant you a long-term recorder. And if I ablate you and I can really prove for 100% that you're AF-free after 6 months, maybe then I can think of stopping it. Although I would warn him that maybe just his clinical risk profile is a risk for thromboembolism even without atrial fibrillation per se. We don't have the data in that respect. But the only condition I would allow him in going for ablation and stopping is when I have a long-term recording at hand.
I think that's very wise, especially to let the patient know that there are no data indicating that he will do, no hard data indicating that he will do good without anticoagulation, and that it's not adherent with our guidelines. That's a sentence that I always put on the table and tell the patient it's not according to our guidelines. We can do it. It's an individual decision making, and residual risks remain even if we are successful with catheter ablation.
But I have to say, we have recently analyzed some of the patients we have treated with again, with questions say whether you can stop AF, and I have to say, with my disappointment, you will find some kind of AF again and again. In Holter, even Holter, I mean, without going into implantable device in about 80% of cases. So, which tells me that, again, you are able to, symptomatically speaking, we are not more symptomatic, but you still see some short runs of that. And when you come to that, say, I am not be able to stop AF, or I will not do that. Because, you know, again, if you say, well, the reason is even some minutes of AF might be of danger, I would say that is exactly the position. So at the end of the day, we have not been able to stop a single patient from anticoagulation. So with our disappointment and patient disappointment, because again, this is the expectation is.
But I think there are patients that are fully free. And what would you do then?
But it's a minority. It's a minority, and I would say is at least we are not good enough probably as you are. But I would say no more than 20. I mean, our data say that 20%, no more.
Maybe in many patients it's a similar situation like heart failure. So there are multiple causes, but one manifestation, and also maybe atrial fibrillation in a later stage. It's like electrical failure of atria, and you need some continuous treatment with anticoagulation drugs to prevent some adverse outcomes. Like in heart failure, you will not stop medication if patient is doing well, because it's an end stage of disease. So maybe in some patients we have to admit this.
It's also important to remember that the relationship between stroke and AF is not the relationship between the rhythm and stroke. That's an assumption, but it's not actually proven. So we don't know that maintaining someone in sinus rhythm means that they're not going to have a stroke. There may be some other factor in AF that contributes.
Yeah, clearly you see if there is a dysfunctional appendage, low velocities, smoke-like echoes. So even the patient has sinus rhythm, or even after cardioversion, they still have very high risk for stroke, because the disease is there and not just rhythm that plays a role.
Could I say two things quickly? One is that the CHA2DS2-VASc score is a very good scoring system, a CHADS-2 VASC score of 2 could mean you've had a stroke, or it could mean you're 65 and female. And you know, if somebody's had a stroke, I certainly wouldn't ever stop their anticoagulation, irrespective of what the ablation result was, whereas I might, in a 65-year-old female, stop the anticoagulation. So again, individual patients need to be considered when we're making these decisions. The second thing I would say is that and this is really for the sort of general cardiology population, even for the general practitioner population, where patients have had a cardioversion for atrial fibrillation and are in sinus rhythm afterwards, a very common misconception is that it's okay to stop anticoagulation then. And I've seen that many times where patients have been cardioverted and their anticoagulation discontinued by virtue of being in sinus rhythm without any due care and attention paid to their stroke risk profile. And I'm not sure how wide the uptake is of the CHADS-2 score and the CHADS-2 VASC score in stroke risk profiling atrial fibrillation. But for me, this is the critical issue in management of patients with atrial fibrillation. Symptoms, when you tell patients, what I say to them is symptoms you can live with. No matter how bad they are, you can live with them. If you have a stroke and can't speak and can't eat, this you cannot live with. So it's a very different impact on the patient of stroke versus symptoms for atrial fibrillation.